invitation. I always think it's amazing, having worked at the hospital for a very long time, to walk into a room and see a whole other chapter, of people who are all, devoted to taking care of children. And my understanding is that you all have a pretty robust network already and a deep interest in children and neurodevelopmental outcomes. And you're thinking a little bit about broadening that from a global perspective. So that's really what I wanted to talk about today, was a global network that we started here, centralized here of children's, started in 2000. And I'll just tell you the story of it, and then just ways that we're using it for global health research, and that obviously the question underneath the question, is there any way it would be useful to any of you to expand the boundaries of your work from a global perspective. The initiative is a quality improvement initiative. Its name is the International Quality Improvement Collaborative for Congenital Heart Disease, improving care in low and middle income countries. And I'll tell you just a little bit more about that. That's probably that way. It worked that way before. Okay. Just to set the stage, though, and I realized I didn't know who the audience was. I assume people are familiar with congenital heart disease. It's the #1 birth defect. It's a major cause of infant mortality here and elsewhere. But we have very large, very internationally famous program here. We get kids from all over the country and beyond and argue about the details of their care. But the bigger picture, the public health picture, the global health equity picture for congenital heart disease care is really stark. And literally the figure is 9 out of 10 people born with congenital heart defects in the world do not have access to any life-saving treatment. So, the nuance upstairs about sort of, pales a little bit into, understanding this reality. And so this is just a slide. I realize my titles are going to be cut off by the share, but just to say, this is a slide a few years ago to the global burden of diseases. Here's some colleagues that were spearheaded at Children's National in DC, started to look at congenital heart defects more clearly. And this is, one of their slides from the Global Burden of Diseases initiative, showing, the disability adjusted life years for congenital heart disease around the world. And, red is high and blue is low. And, it's pretty easy to see that there's just a huge disparity in disability, death and disability, CHD. This is from a combination of factors of where babies are actually being born. There's a lot more babies being born in Latin America, Asia, India, and Africa. And the fact that there are really very few robust cardiac surgical programs or even cardiac cath labs in those areas that results in this reality. And if I keep just want to advance it. There you go. This is another really fantastic study that was done by Su et al. Using the global burden of disease data. They actually looked over a long period of time from 1990 to 2019. And as many of you know, here in the United States, death and disability from congenital heart disease has gotten enormously better over that period of time. But what they showed in this slide, first of all, over here, the percentage of people dying, the gray is congenital heart disease. So the percentage of deaths in the low income countries is much higher. And then the rate of improvement, this is the rate of improvement in the higher income countries, and this is the rate of improvement in the low income countries. And so the disparity is actually getting worse as things are getting better in the United States and Europe. And so that's the reason really for our initiative. And so, as I said, this is a quality improvement initiative. So I told you the title, but the vision is really to have a collaborative of healthcare teams from around the world, to focus on safety and quality of care for congenital heart disease with a very specific, mission to reduce death and major complications. And so this is not a new concept. The idea of a Quality Improvement Collaborative was actually developed by the Institute of Healthcare Improvement in the United States. They call it the Breakthrough Series or the Breakthrough Learning Series. Boston Children's participates in a number of these different quality improvement collaboratives. I have helped start some of the ones in our country, including one called the National Pediatric Cardiology Quality Improvement Collaborative, which, by the way, would be another fantastic source of data for research. It's focused on care for single ventricle patients and hypoplastic heart syndrome. And it's still in existence, and expanding in its reach. And many centers in the United States are part of it. So I personally learned how to do a quality improvement collaborative by setting up the MPC QIC by quality improvement experts, and then said, well, why don't we do something like that globally to try to address the more global issue for CHD. And I have partnered with a number of the bigger and more interested NGOs that are working in this area. Probably the most important one is Children's Heart Link. Children's Heart Link is based in Minnesota. They're one of the top NGOs in the United States working in this area. And there are others as well. There's a really new, interesting one, Global Arch, which is trying to develop parent and patient advocacy efforts around the world by pooling a network of all of the parent and patient advocacy groups in all the countries. I think there's over 100 organizations that have joined Global Arch, and that's relatively new activity. And this is just a map from 2024 of where our sites are around the world. And we started with just a handful of sites chosen by our NGOs, and it's just grown organically in low and middle income centers. And there's an increasing footprint in Africa, where the care is really at a completely lower level than it is in other places. My team is going to Brazil. There's about, I think, 8 programs in Brazil right now. And next week, we're going to Brazil, and we're going to be visiting all of our partners in Brazil as part of the project. A few years ago, we were able to stand up a catheterization registry. So most big programs have both surgeries and cath. But a couple of programs have joined just the cath part of the registry. And we collect data. The database is housed here at Boston Children's. And I'll tell you more about how that's set up at the end. But one of the most interesting things that we do is that we audit the results. In fact, that's what our teams will be doing when we go to Brazil. We do a 10% random sample audit of all the core variables to be sure that the data is robust. And that's a heavy lift as the project has expanded, but it's really important. And all of the research we do is from the sites that passed the data audit. Doesn't mean their data were perfect, but it was sort of above the bar to believe it's credible, reliable information. And this will just show you when we first started this, and I was going to the global meetings where people were convening over these subjects, people said, we can't do anything because we don't have any data. We just don't even know what's going on. That's not true now. Our database has over 180,000 cases of congenital heart disease as it's grown over time. So now we have a lot of information. And then the first ever data about what's going on in the cath labs is coming in too. So we're now almost at 25,000 cases of congenital heart disease catheterizations being performed in partner sites. And so it's a quality improvement initiative. So the biggest thing that we're doing is giving people a benchmarking report every year, where they can see what their case mix is compared to the other sites in the program. They can see how their outcomes compare, and they can understand their risk-adjusted outcomes, in order to just gauge where they're at or gauge if they're improving over time. And we're always just really important to say that although the data is housed here at Boston Children's, the work is being done by the local programs. And this is like any other quality improvement collaborative. We're not forcing people or having rules. You have to do this, you have to do that. But if sites really want to benefit from the project, they have to stand up a local team and they have to, do things locally in order to make their care better. Just like anywhere else. But this is just to show these teams. We also have a really heavy emphasis on multidisciplinary care. So the teams typically will have physicians, surgeons, anesthesiologists, intensivists, cardiologists, as well as nurses and nurse leaders. And so one of the things that's really interesting when you do global work is that, you're really doing capacity building. And there's some important capacities that kind of centers are developing along with the project. One is, by the way, the ability to collect data and get it, reliably into the computer. That's a skill, that a program has to develop or a center has to develop. Another one is quality improvement. So what we do is insert, key quality improvement tools directly into the project. And this one is like, I was a quality and safety officer at Boston Children's for over a decade. So in terms of QI, this is my favorite QI tool because I'm sort of a big picture person. And it's the key driver diagram. And so it's really setting out the intent of what the focus of the project will be. And in our project for the surgical program, it's to reduce mortality and get kids to survive. And then we focus on 3 different areas: safe perioperative practice, which is a lot about the handoffs between the various team members from the OR to the ICU, et cetera, and all that communication. Reducing infections, the surgeons globally just said it was just a tragedy to put all the resources into having a baby have surgery, get them through all that, and to have them just die of an infection. And our data shows that you're about 4 times more likely to die if you have a major infection after your operation than if you don't. And then a really, really big one is team-based practice. When you go to globally, especially the physician space is relatively similarly viewed as it is here, but the other professionals, especially the nurses, can be practicing at a much, much lower level. We need to raise the practice level for them in order to have them be true partners in getting kids to survive surgery. So we do a ton of work around empowering nurses, lab techs, other people like that. And this is just a couple of the tools. This is from Guatemala. Some of you who've been here for a while know Dr. Castaneda, who was here many years ago, built our program here went home to Guatemala after, and he died a couple of years ago. But this is the 5 moments of hand hygiene, and it's the same ones that are, posted upstairs in our units. But this is sort of in Guatemala, reminding people of the #1 way to reduce infections. And this is just another one. Right around the time that we were starting the project, the world, under Atul Gawande's work here in the US, the WHO had just said that every surgical program, every operating room in the world should use a safety checklist. And so we inserted a safety checklist into our project as part of the first key driver. And these are the different surgical safety checklists, that people have kind of developed in their programs, based on learnings that we've helped them provide. And just a little bit about the data. This is our most recent outcome. So this was data from 41 programs that participated sufficiently and passed the audit, about 13,000 cases. And, when I show this in my field, people are surprised, that things are going so well. Mortality is common after congenital heart disease, but um, it's always hard to know what an overall number means without knowing what the case mix is, because, the mortality rate for a simple ASD surgery should be near zero, and the mortality rate for a hypoplast, even here, maybe 20%. So, it's hard to know what the number means, but what the number is 4.4%, and the 30-day mortality is about 4.8. And the infection rates remain high, particularly the rates of sepsis after surgery. I didn't include the slide with a full RACS model, but years ago, my partner, Kim Gabro here at Boston Children's, and I developed one of the systems to understand outcomes for congenital heart disease, mortality outcomes. It's called RACS, the risk adjustment for congenital heart surgery methodology. And we use that methodology in IQIC as well. And it basically, there's many, many kinds of congenital heart disease. And so we group them together into risk categories for death. And those are called the RACS categories. And then there's some other variables that are included in our final model, such as age and prematurity, things like that. This basically shows types of surgeries that are being done around the world. Most surgeons in the US will know what their mortality rate is by category, either by RACS or one of the STS methods here. But the most important thing to say is that common things are common. So the lower risk, more common lesions are, more than half the case mix. And everybody gets really talking about, like, the stage ones are over here. So they're extremely rare, so it's really about moving this part to do better, to really, really make a difference. But the surgeons around the world will get a viewpoint on their cases and how they compare by looking at their data and how the mortality differs, from where it is in the US. So we've written papers about that. A lot of the research that we've done with the IQIC database is using the data itself, even though it's limited. The data collection burden globally is very high. So what the leaders of the project have done have kept the data set to a more minimal level. And it's not a longitudinal data set, it's just a short-term outcome data set, but it still has a lot of information. And this is just an example, tetralogy of flow is one of the more common lesions. And the point of this paper was to see, how the IQIC sites were doing at this time, which is a couple years ago. I think it was published in 2018. The TOF mortality for primary repair globally was 3.3%. And at that time, the STS was 1.3, and the EACTS data set was 2.5. So that's still, threefold different, but it's encouraging. And that's really important because knowing and showing that sites can succeed is really important for having the programs have global investment so they can continue their work. And then we've been able to go a layer down a little bit, with the data that we have. This woman is a Harvard Medical student. She just graduated last year, Rachel Wittenberg. She's written a couple of great papers as part of her MPH. She's just started as a internal medicine resident at MGH, and she's fantastic. But she was able to look at the influence of malnutrition on our two most important outcomes, which are in-hospital mortality and major infection. And she also looked at longer ICU stay, and this was just published recently in JAHA. And it's really interesting. Surgeons around the world always say, it's why do we need to have a global collaborative? Why don't we just do STS? They say, well, it just wouldn't be fair because the kids that we're seeing and the cases we're seeing are so different. And this is just looking at malnutrition. These are using the WHO standards for malnutrition, not the CDC standards, the global ones, but using the weight for height Z-score, which is the best measure of malnutrition. These are for VSD patients. You can see how extreme the level of malnutrition can be at the time of surgery. Rachel was able to show some thresholds for where it really makes a difference in the outcomes, and it definitely increases length of stay. So we've used the full REX model and the more recent cases, actually using about 68,000 cases from 2016 and 2020 as a baseline, just to see how mortality has changed for the IQIC sites over time. This isn't an apples to apples in comparison because some sites have joined and some have left, but you can see that in general, there's been a really nice improvement in mortality, and these are standardized mortality ratios for the whole collaborative, and it's been pretty sustained, which is really nice. I didn't bring the graph or similar graph for infections, but it's not quite as pretty a picture for infections. Infections have come down, but then they went back up across the collaborative. And that's true here too. Anytime people take that eye off the ball, major infections increase. They're sort of a must-do every day kind of thing. And so just as I was saying before, in 2008, the global community said, we can't say much about CHD because we just don't have any data. Obviously, that's less true. I see still a void there. But having the data and information is really critical to advocating for global health resources. The major NGO I told you about, Children's HeartLink, wrote a 4-part series about this, and they literally named it The Case for the Invisible Child. The reason for that was often CHD can look invisible in the statistics because it's never diagnosed. It's assumed to be neonatal sepsis or death at birth for some reason, or respiratory, something like that, when in fact the underlying issue was congenital heart disease. And they sort of make this case and made a blueprint for how to make it better. The World Congress for Pediatric Cardiology and Cardiac Surgery was here in the United States in Washington in 2023. And a lot of the global groups got together and put out a call to action about how to make it better. And one of the components of it was workforce, one was resources, but one was data as well to really know what's going on. What's happening next is that the global community has gotten some inroads at WHO to get WHO to pass what's called a resolution. And this may happen in 2026. And if it does, it will be the key that will make it more clear that WHO wants programs around the world, health ministers and the like, to invest in congenital heart disease and things that they should do to get there. There have been some other local successes. I don't know if you guys know Gene Bookman, who's from at the medical school in I think it's called Global Equity and Health Surgery Department. He's also at the Brigham. He's going up for a professor now. But he was an author on the Lancet Commission series, where the Lancet will take on an issue and do a whole evaluation and do a Lancet Commission paper. And he chaired the NCD one, and he made sure that congenital heart disease was included as a non-communicable disease for a global surgery. And he also started a poverty network called and tapped into some other global work that's going on in order to really advance global health for non-communicable diseases. And the reason for that is that a lot of the global health work to date has been for infectious diseases. And so anything that's not in infectious diseases has been left out. And then when they shifted over to look at non-infectious diseases and they went into the prevention space. So tobacco cessation, weight management, things, diet and exercise. They didn't go into the treatment space. So if you had congenital heart disease, for example, you kind of got left out of that story, as did other NCDs. And so I know you guys are all researchers. So just to say, I will, beyond the data from the registry, we've made a few inroads into doing research, leveraging the registry. And the permissions around that are just a little bit different, but we did 2 papers during COVID leveraging the registry. One was more the experience of congenital heart patients experiencing COVID in the US and around the world. The other was the impact of COVID on programs. That was more of a mixed methods study, including surveys of programs that were critical access centers around the world. We've also done an infrastructure survey and the like. There's, I would say we haven't gone down this road very far, but obviously, we've always been interested in doing more, than we're doing now. And just to say, although we don't have criteria for who joins our project or doesn't join our project, there's some tiny programs, there's very clinical programs, there's private hospitals. We do have many of the very top centers of excellence in pediatrics around the world that are part of our project. I just listed some here on this slide. And the reason for that is that there are several NGOs that are going to help build programs that don't exist. We're not doing that. We're leaving that to others. So programs that are part of our project need to have an existing congenital heart program, which is already a pretty heavy lift, globally. And they also have to have an interest in getting better, and a will to participate and an ability to have at least enough resources to put data in the computer and the like. So we have some really top programs, many of which are part of academic centers and are very interested in themselves and doing research. And just a word or two about the data management. If you all were thinking of going down this road for your own research purposes, this is just how we've done it now. And we've worked this out with the Boston Children's Legal Office. They're the ones who set up our framework for doing this. The data repository is stored here on our servers, research servers. The registry only includes de-identified data, and that was really a critical trick for making things easier. We have an open IRB protocol that allows researchers at Boston Children's to do research with the data. Data that requires additional data, like the COVID projects, for example, require specific IRB approval. They go beyond the general approval that we have. The only thing really formal about joining IQIC is if you are going to submit data, we have a data use agreement that's between the program and Boston Children that specifies the terms, of the data exchange. We don't govern what programs need to get internally in order to participate. Even here, if you're participating in a quality improvement registry, you don't always need IRB approval, but if you're collecting some data, you do. There are programs that require government approval in order to participate, like in Pakistan, literally the government has to agree. And there are other programs that really don't need any internal approval. And we kind of leave that to the sites, in this project. The aggregate data, sites obviously own their own data and can do anything they want with it. They can use the aggregate data for research, but we don't give line item data to anyone who's not on our IRB without, unless it was under some other research construct. And the basic idea is that site-specific data can't be identified without permission. And it doesn't just mean naming the site. For example, if there's only one program in Peru as part of the project and you showed a Peruvian site data, you would be unmasking that site. So on the other hand, sites themselves are usually pretty open, to being, allowing unmasking, if needed. And so the other, good thing about quality improvement collaboratives is there's things called learning sessions. This was just a learning session at the American College of Cardiology Heart House that was part of the World Congress. But people have formed a network, that we can leverage. So that's pretty much all I wanted to say. And I don't know what all of what I just said you guys might be the most interested in. But I'm happy to answer any questions or hear more about what your groups are thinking about, might, take your work forward.
Thanks so much.
Any questions?
Actually, I have two questions. One of which is pretty straightforward, I think, and that has to do with the mortality rate falling. But then you said something about the infection rate actually increasing, and what's the disconnect between an increase in infection rate and not a change in mortality?
Yeah, good question. Center to center, that might be different. You can survive with an infection, so they're not directly correlated.
I was wondering if that implied a better infection management.
Oh, yeah, possibly, or if the term is called failure to rescue, means the ability to rescue someone given that you had a complication. That's what that term means. So you could argue that the failure to rescue rate is improving, perhaps, or there's earlier detection, for example. It's a good question. I think when I look at it from a QI lens, it always happens, like right here in our ICU. What will happen is rates go up. So there's two issues. Like we're working with a program in Dhaka right now. It's a new Children's HeartLink site, and they're focused on it. It's one of the only programs in Bangladesh. They're doing over 1,000 cases a year. They have kids pouring in the doors with a long waiting list, and their infection rate's 3 times higher. Risk-adjusted infection rate's 3 times higher than IQIC site. So it's really high. That program has to go figure out the basics. Like they've got a problem. And that's where infection control can jump in or whatever. Once programs kind of get past that, and they're in a more stable place, what will happen is they'll put a lot of effort into a lot of initiatives and focus on hand hygiene or whatever. And then it's no longer the thing. The world focuses on something else and the infection rates always go up because people stop doing the practices. Someone just told me, I was on call this past weekend, that our fellows in cardiology got a 0 on the children's audit for compliance with hand hygiene in our cardiac program. So, I mean, that's just the world of QI, and human nature, and I'm sure it's not really 0, it's just on the audit, maybe it was, but that's true globally too. But they have so much more. They have just a much more chaotic workforce, people coming in and out and less trained people. So that's part of why it's so hard. It's even harder now.
And then the second question had to do with WHO and its role over the years and what's going to happen with the future.
Yeah, like since we're not heard of it. And you got involved in this, you start to learn a little bit about the global health world. And I will say the vice president of strategy at Children's Heart Link. Sister Jaleva is amazing. And we've all learned a lot from her, but the trick is that the money that is put into global health, which rich countries pour into and poor countries devote their limited resources to, NGOs often are tagged with, are dependent on those the focus areas. So right now, and so if you're not named in those focus areas, it's essentially cutting off the many revenue streams that come with it. So if you tried to go get philanthropic dollars or internal dollars or a grant, and they're not linked to the different I'm just blanking on the term right now, to the indices, right now it's the 2030 indices, the under 5 mortality rate is the big one for us, and the infant mortality rate, of course, and there's targets for that. If you're named and linked there, you open up the different revenue streams. That's why it's so important. That's why something as simple as Gene Bookman, who knew about congenital heart disease from us, making sure it was named in a Lancet commission so that it's more likely to be named. And the WHO resolution probably will still go forward. Like, I don't think Children's Heart Link and the global advocates are going to change their mind because the US isn't part of WHO. So hopefully they're on track there. It's a big milestone if there's really a resolution. There was one a few years ago for rheumatic heart disease, and you could see it immediately in the questions people are asking. And, so that's all I can say, but it's important. But that's the reason. There's a lot of money that's tied to hitting those what the WHO says is important as the target goals for the world.
Thanks.
Yeah, and historically, it's been all, like I said before, a lot of infectious disease work or prevention. And the problem is, if you need surgery to correct tetralogy of flow, smoking cessation gets you there. You need a hospital with an OR and a surgeon.
I'm just curious, when you were talking about the key drivers, one of the initiatives being creating safety checklists for care, how does your team standardize those checklists across different sites globally, and what do some of those practices include?
Yeah, so the way we've been doing the educational program is literally through webinars, through which, and we've done some more formal things as well, but we'll literally have a webinar that says, here's, Luis Quinones, one of our surgeons here, actually does the WHO surgical safety check, and he says, here's why it's important, and here's what ours looks like, and here's how we do it. And then one of the things we do is model it on the webinars. So like the last part of the checklist here, some of it is pre-procedure, some of it's inter-procedure, and then the last piece is the handoff to the ICU. So we'll go here now, even in the time I've been here, that's been more and more formalized. So right now, when a baby comes upstairs to our ICU, there's this push pause handoff that happens, and it's become more scripted and structured over time. But even the nurses play a role, anesthesiologists play a role, the surgeons are handing off to the intensivist. So what we'll do is actually film that, an actual one, so that we then show, yes, a nurse actually spoke, because when you go globally, the nurses are like timid, hiding in the background. There's gender issues, and there's hierarchical issues between doctors and nurses. They're like here it's like this, and there it's like this, so the nurses have to be empowered and shown, like, yes, speak up. And we have our nurses showing, there were two, Tony and Jason, and they would be like, doctor, I have a concern. And that's how they get the attention of the physician, because that's what the nurses don't do in Guatemala. And so we were trying to have them model it so they can see what it might look like. And then they have to try to do it. And then if they say, oh, we do it differently, like we don't have that person there, we say, okay, you should do it for you, not for us, not our way. Yeah. Thank you. We have to be really careful because we have a lot more people than typically there are, and the workforce is just much smaller. Yeah.
I have a question.
Yeah.
Have you noticed in the data that there's a difference in the types of diagnoses in different countries? Like, is there a distribution that's higher in one than another? And is that like genetic and ancestral components, or is that diagnostic medical imaging?
It's a really good question. We're very aware that we don't have population-based data. We have the data we have, and there's filters to get into our data set, but it's still a very relevant question. And there are definitely interesting differences. I also wearing a totally other hat that we won't go into here. I'm interested in pulmonary vein stenosis, so I'm very interested in the TAPVR population. And there's pockets in Latin America and South India that have a ton of cases, and other places don't. And the most fascinating one of all was left heart syndrome, so aortic stenosis. So we brought together a team to design the CAF registry. That's how we did it, to create these registries. And so we had people from, different parts of the world, and this one of the interventionists was from Malaysia. And the way we decided to do that registry was we wanted some information on all CAFs and some more detailed information. And I think we chose 5 lesions. And everybody wanted aortic stenosis because it's a super common lesion in the US. Bicuspid aortic valve is like the most common lesion. You've got the whole spectrum of left heart lesions. AS is dilated in the cath lab as primary treatment. It made enormous sense. And the docs in Asia said, I don't know, we never see that. And that's still in my mind, by the way. Excuse me? They're like, why would we bother? Because we just don't see those cases. And it was like, that can't be true. But it is. So, that's what we're learning. Unfortunately, but like I said, the best data on incidence prevalence is the global burden data. And that's limited by, what's available diagnostically in the country. So it's probably not good enough for the question you're asking them. How could you learn more about this? Absolutely.
So you were saying that that's not something that you'd be able to look at necessarily with the IQIC data that you've had?
Well, we're limited because of the lack of it being population data, but one could, like any other, using existing data sets, try to overcome those weaknesses. We haven't tried. Because there are areas where we may, like the COVID paper, we focused on what were called critical access centers, and it was more to make the point that you need to continue these programs even if we have COVID, because otherwise there's no care. And so the ones that we chose for that project, there were about 6, they were the only program in their region. So you wouldn't really know who was born in the region, but you would know who was diagnosed and made it to a treatment center region, and that might be a reasonable surrogate. So within limitations, you could do that. And there are programs that have, genetic programs or genetic profiling. They're just not part of our database. You'd have to layer a research study on top of it, of the network. And that could certainly be done. And you could probably use the data, descriptive differences within the descriptive data, given that we have it, to design the best study, like to choose where to go, for example. Yeah, it's absolutely, that kind of thing.
And then I guess my second question to that was, do you notice in the centers that have access to MRI and don't have access to MRI, a difference in the types of diagnoses and surgeries that the infants would then end up having if they're an early confirmed diagnosis or it has to be postnatal diagnosis?
You're talking about postnatal MRI or
Or I guess like,
congenital.
I guess in most of those sites, it would probably be postnatal. But I'm thinking about, so the site I came from in London did fetal MRI to confirm the diagnosis from ultrasound. And that really shifted the types of diagnoses that they were getting, and they could kind of confirm things fetally instead of having to wait for a postnatal. So the surgical planning was affected by that, I think.
Even here,
Yeah.
fetal MRI is pretty rare. It's mostly fetal echoes. So
Okay.
yeah, so I think it's more maybe in the trickier cases, or alternatively where there's more complex malformations, not just the cardiac piece. So, but honestly, the first question would be, do we have MRI?
Yeah.
Before we had fetal MRI. You know, and in the infrastructure survey, which is a little bit old, and I think it was about half the programs had access to MRI,
Okay.
and about half were doing fetal cases. But it's more and more, you know, as the technology is evolving and programs are advancing, you know, to have a fetal diagnosis.
Yeah. I guess I was kind of wondering as well, like what difference that makes. You know, this argument of like how much better is it just using
Even here, you know,
ultrasound?
the data's a little bit better, but not dramatically so when it's been studied in the US. So, you know, I think one of the conclusions in the infrastructure paper, if I'm remembering, Isaac Wamala, who did a postdoc here and he's training to be a cardiac, he's from Uganda, I think originally, but he's in Germany now. He concluded that, you know, so there's sort of almost like two tiers of programs. And the United States, just a bunch of docs here just issued a controversial paper in congenital heart disease saying even in the US, there's two tiers of program. You know, there's normal programs that do all the common stuff, and then there's the more tertiary programs that do the more complicated things. Globally, that's really important. You know, programs are first establishing themselves to do the basic things well, which are the more common things, because they're critical access for services, and then moving to the more complex things. But one of the global advocacy papers that we wrote said, if you're going to make that transition and you're going to try to do more, there's certain things you're going to need. And like an MRI or a three-dimensional diagnosis is one, or a more established fetal network might be another, you know, because otherwise you don't have the tool that you need to do the more complicated things. So there's this two-tier idea. I don't know if that helps, but when you go then and, you know, turn your eyes towards more sophisticated research, you know, perhaps if it's in that more complex space, you would want to be networking with those programs. Those are already pretty high level programs. If you were wanting to do more basic work, you know, on the fundamentals, you might be working in the lower level programs. They might have less resources. So it kind of would depend on which part of it you were interested in, which would be preferable. But the low resource programs, you know, they may have way less. Is there anybody here doing global health research? Doing anything outside children? Or yeah.
We're studying neonatal sepsis in Vietnam.
Neonatal sepsis in Vietnam.
Yes, in Bangladesh, Europe defects.
Sorry?
Europe defects in Bangladesh.
In Bangladesh. Interesting.
Congenital heart disease, but in the US as well.
I see. Yeah, I mean, both of those, you know, are very, very kindred to what we're doing. We have a number of Vietnamese programs. There's a lot of interest in the pediatric congenital heart community in Vietnam. There's been a lot of people going there, investing in it. Our educational program, years ago, Patty Hickey from here was asked to teach a whole educational program in her nurses taught it to all the Vietnamese pediatric hospitals. And actually some of the educational work we're doing was modeled after that. So there's a nice Vietnamese network there. Might be interesting to know if the neonatal sepsis rates were similar to the post-op sepsis rate. You know, that would be something one could do. You know, yeah, that would be just a low-hanging fruit question. Yeah. And the other one in Bangladesh, like I said, we're just starting this relationship with program in Dhaka. So I don't know which hospital you're working with.
That's a great question. The data is from the Masundar lab.
Where?
Masundar lab, Maitri Masundar. She's
A laboratory there.
yeah. Well, here at PCH.
Oh, here at
She's the
PCH.
one.
Yeah, I mean,
That's the connection. Yeah.
we've been meeting regularly with the surgeon and their team from NHF Hospital in Dhaka. So I'd have to look up its long name, you know. But Children's Heartlink is very focused there. So if there's a way to tap into that, like I said, they're doing this massive surgical program, might be interesting. Yeah. Oh, sorry.
Sorry, I was just saying the Bangladesh cohort is community based, so not
Oh.
at a hospital.